In patient who requires extended treatment, reduced dose of DOAC is preferred to aspirin. But in patients who refuse anticoagulation, aspirin can be used instead, but aspirin is not recommended in patients eligible for anticoagulation. In patients with decreased renal function, DOAC or warfarin can be used, but creatinine clearance is less than 15 milliliter per minute. Low molecular weight heparin, unfractionated heparin, or warfarin is recommended. In patients who are undergoing venous stenting, anticoagulation therapy without concomitant antiplatelets is recommended, initiated with low molecular weight heparin for 1 month, then DOAC at least for 3 to 6 months. In CHEST guideline, perioperative anticoagulation management is added, and in patients who are taking warfarin, warfarin can be stopped 5 days prior to the surgery, then resumed on the day of surgery in high-risk patient. And bridging with low molecular weight heparin can be done in patients whose risk of thrombotic event is high. For DOAC, in patients with high risk of bleeding, DOAC can be stopped 2 days prior to the surgery, then resumed 2 days after the surgery. Let's look at the invasive treatment. So far, the evidence and efficacy is very limited in quality and quantity. In ATTRACT trial, there was no difference in PTS incidence, but higher major bleeding incidence in PCDT. In subgroup with iliofemoral DVT, the PTS severity was lower, so we are waiting for definite benefit with CDT. In NICE guideline, candidates for catheter-directed thrombolytic therapy is very strict in patients with symptoms lasting less than 14 days and good functional status and a life expectancy of 1 year or more and a low risk of bleeding. And it is recommended to treat in iliofemoral DVT, but not in distal DVT. There are many devices in US, at least 55 catheters, and the technique can be divided into mechanical thrombectomy, aspirational thrombectomy, rheolytic therapy, rotational thrombectomy, and ultrasound-enhanced thrombolysis. Catheter-directed thrombolysis can reduce dose of thrombolytics, and thus it can reduce risk of bleeding. It includes ECOS, Angiojet, JETi, Cleaner, and Bashir. And a commonly used regimen in TPA, 0.5 to 1 milligram per hour for 6 to 24 hours. Mechanical fragmentation of thrombus can further accelerate thrombolytic time, and then it can reduce the lytic exposure. It includes Indigo system, ClotTriever, Aspirex, Cleaner, Angiojet, JETi. Let's look at commonly used 3 techniques. Angiojet is only device that can be used in Korea so far. When we look at the Pearl registry in 2015, it includes 329 patients. The result is quite good. Complete or 50 to 99 clot reduction in 96% of patients. Total procedure time in 73% of patients was less than 24 hours. Bleeding complication occurred in 4.5% of patients, none of which were related to the Angiojet device. Next is Indigo system. Earlier, penumbra catheter was used in usually cardiac procedures, and it was not very commonly used because it has no steerability, continuous blood loss, flimsy tips, and small caliber. But it has evolved much, and now it is quite widely used. We are waiting for the BOLD trial, which will be completed in 2027. ClotTriever, which is suitable for vessel ranging from 6 to 16 millimeter, is another device we are waiting for. And I heard that Japanese doctors are also waiting for this device. And I heard experienced doctors says that this device is very simple and effective, even for chronic thrombus. So we are waiting for it too. let's move it to the 34 second. Sangju Yon, can you advance a little bit? No, I couldn't find clot river animation. It is not available in YouTube. Thank you. It is a smaller catheter, but I think the principle is pretty much the same. It has sheath and catheter system. When you put the sheath first, then advance the catheter inside, go over to the thrombus, then open the catheter and capture the clot inside the sheath, then pull it out. So it is very simple and it does not need thrombolytics, so it is very simple and effective. Let's look at the data. From clot registry published in 2024, more than 75 thrombus removal was achieved, even for chronic thrombus in 83% of patients. And no thrombolytics were used during the procedure. It is ended by a single session in 99%, and median hospital stay was just 1 day. Another data published in 2023, it includes 499 patients, and it ended in a single session in 99%, and more than 75% thrombus removal was achieved in 91%. And there was device-related serious adverse event in 0.2% that was fatal PE. It happened during the IVC thrombus removal. So we are waiting for another study result, which was completed in 2025, which compared mechanical thrombectomy versus anticoagulation. This is a very interesting study published last year. It is retrospective cohort analysis from clot river registry and ATTRACT trials history cohort, and it confined to the iliofemoral DVT. When compared 130 patients pairs, no PTS at 12 months was 83% in clot river group and 63% in ATTRACT group. Single session treatment was achieved in 97% of clot river group and 27% in ATTRACT trial group. And mean hospital stay was also 1/3, almost half in clot river group. I think the result is very promising with this device. So in conclusion, after the widespread use of DOACs, the medical management of DVT has not undergone significant changes. Pharmacomechanical thrombectomy devices are expected to reduce hospital stay, decrease procedure time, and lower the incidence of post-thrombotic syndrome. We need to await the results of ongoing randomized control trials. Thank you very much for your attention.
Thank you very much. So we will have a discussion. Dr. Sakamoto Kazuki, please start your question.
I'm Dr. Sakamoto from Osaka. Thank you for your good presentation, and I could get new information. And I want to ask about varicose vein thrombosis. I want to know about. We sometimes find varicose vein thrombosis. How do you manage great saphenous vein thrombosis? Surgery or anticoagulation therapy? How about great saphenous vein thrombosis, varicose vein?
Thank you very much for your practical question. If the patient has varicose vein and who has a GSV thrombosis or SSV thrombosis, then I used to operate, but it depends on the location of thrombus. If it is goes up to the junction, I usually treat with anticoagulation, then I decide whether to the timing of procedure. And when it goes below the knee or confined to some area, then I can discuss with the patient and proceed the procedure.
Which is often surgery or anticoagulation therapy?
It depends if there is varicose vein or not. That is the most important thing. And if the patient has varicose vein, I usually perform surgery.
Surgery first.
Yes. And sometimes people don't have varicose vein, but sometimes people have prothrombotic condition. Then I used to perform anticoagulation.
Okay, thank you. And I have one question. When DVT or varicose vein thrombosis occur, to find risk factor, what types of blood test do you do?
Thank you for your nice question. In was it ASH guideline? What is that? The blood test should be reserved such a group of patients. So I do not perform usually for this test, but when it is needed, I used to antiphospholipid antibody. That is most common in my group, and we don't have factor V Leiden mutation. We don't have it, so we don't prescribe that test. And any other rheumatic disease test, including cardiolipin antibody test. Thank you.
Okay, thank you very much.
Thank you very much. Do anybody have more questions? I just have a comment. We in Japan, we are not approved to use a low molecular weight heparin, and we do not have urokinase. And on the contrary, we have Angiojet. We have a Penumbra will be approved very soon, and also Inari Clotrimazole will be approved very soon. Yes.
Thank you.
Okay, thank you very much. I would like to the next speaker, Dr. Woon Kim, and the Thoracic and Cardiovascular Department, National Medical Center, Seoul in Korea. And the topic is that the evidence-based standard protocol of the duplex scan for the varicose vein. Welcome.
Good morning, everyone. Thanks for inviting me this great meeting, and I'm especially grateful to Dr. Makotomo and Dr. Takahiro Imai for giving me this great opportunity to speak. Ultrasound evaluation can be very subjective test, so it must be standardized. Today, I will talk about Korean evidence-based standard protocol of a duplex scan for varicose vein. Recently got certified by the Korean Academy of Medical Science. Let me give you a brief description of our Korean Society for Phlebology. On March 2001, founding general meeting and symposium were held with Professor B.B. Lee as the inaugural chairman. In 2005, there was an exchange between the Korean and Japanese Society of Phlebology. If you look here, you can see a photo of Dr. Takehisa Iwai sensei when he was young. Our venous society doesn't have as long history as Japanese Society of Phlebology. In 2015, the UIP Seoul was successfully hosted. Korean Society for Phlebology is celebrating its 23rd anniversary this year. And presently encompasses a body of 349 members making it, and it stands the Seoul Venous Association in Korea. Now let's get back to the point. These are the low extremity venous ultrasound protocols that can be checked when searching at the Google. And if you look at these various ultrasound protocols, in general, the items that needed to be inspected are all common. The following are the items that must be checked in general low extremity venous ultrasound examinations. And this is the Korean evidence-based ultrasound examination for varicose vein. We created this last year, November. We made a lot of effort to pass the evaluation criteria of Korean Medical Association's treatment guideline. We held several meetings and invited total 11 expert reviewers, and including 5 from private practice to complete survey and review and reflect the results. So after review by the Korean Medical Association Clinical Practice Guideline Expert Committee, it was finally officially registered on last year, November. So let's look at them one by one. So this is 6 key questions and made 15 recommendations based on them. And key question 1, what tests should be performed on patients suspected having varicose veins? And duplex ultrasound is recommended for the first diagnostic test for all patients suspected of chronic venous disease. This is SBS AVF updated guidelines published December 2022. And they recommended ultrasound level of recommendation grade 1, quality evidence B. Also in 2022, also ESBS recommended them as class 1 level B recommendation. So key question 2 is what are the appropriate probes for setting for ultrasound? So for evaluating the ultrasound, typically linear 4 to 14 megahertz transducer for superficial structure. And for deep structure, we can use the lower frequency 2 to 5 megahertz covered linear probe. As you know, measuring reflux measures valve closure time. A criteria for pathologic reflux in the treatment of varicose veins based on numerous research results. So these reflux studies and definitions, as you all know well, Greek-American Dr. Nikos Lavropoulos defined through the study in 2003. And they use this vascular linear probe. And this is 2006 UIP ultrasound's consensus document. And they also use the same linear probe. And this is 2011 SBS AVF guideline. And they also using the same vascular linear probe. So standard ultrasound diagnostic probe is a linear vascular probe. Number 2, testing performed under setting that minimize the artifacts. About ultrasound optimization, PW gain is set appropriately to display only enough flow to indicate respiratory spasticity. If you measure with the gain too high, the original shape of the waveform and the integrity of the test may be distorted. So key question 3, what's the preferred patient position? A standard position of patient during ultrasound examination, low limb is standing position. There are no room for argument because diagnosing the value failure is in the low extremity. The reason why it must be measured standing is that pathophysiologically effect of gravity are better shown. So always exam on the standing position. However, if patient is unable to stand, sit or can be measured in a reverse Trendelenburg position. Quick question 4. We should check the augmentation by this muscle squeezing or a pneumatic compression device. When performing a reflux test, a vein must be measured in longitudinal view. So because of time limit, I'll skip. So in particular, when the angle is greater than 70 degrees, the measurement error rate appears to extremely high. So when observing blood vessel, longitudinal view measurement should be made with the Doppler angle of 45 to 60 degrees. So, because it is for the repeatability and reproducibility of the examination. So all American criteria, they recommend the longitudinal view examination. So this is European guideline. They also said longitudinal view helps to access the reflux flow. So because of time limit, I skip this. And in the case of operating veins, measurement is longitudinal view may be physically difficult, so they can be measured in a transverse view. I skip this. So in the past, in the operating vein, it is only specified as a named vein here, but now it is possible to more accurately confirm the record the location of the operating vein. So ultrasound record is like this. Be sure to record including the augmentation waveform, which is caused by cup compression, and the reflux waveform caused by the retrograde flow are located in the opposite direction here, and it should be recorded the reflux time. And all these association recommend them to document augmentation and reflux flow. This is suggestive form of our vascular society to record after venous ultrasound examination. So ESV guideline 2022 recommend inspection of according to UIP consensus document as earlier. And this is the standard form reporting form in our society. And lack of standardization means lack of quality. So these are the wrong examination of ultrasound images. So ultimately, standardization in diagnosis is very important. That can avoid unnecessary treatment and improve patient outcome at the same time. If you are interested in our evidence-based ultrasound examination, please take a look at the contents published in our Annals of Phlebology journal. Thank you for your attention.
Thank you very much. And are there any questions from the floor or the comment? So, and the Dr. Yamamoto, and could you give that question or the comment, please?
Hi, I'm Takashi Yamamoto. I'm so happy that you are in time.
Yeah.
And I'd like to ask you, because I've read your paper published last year.
Yes.
I've read through it,
Yeah.
and it's very informative, but it's a guideline,
Yeah.
and sometimes guidelines are boring.
Yeah.
So I couldn't find your passion there. So I'd like to ask you what you're passionate in this field.
My passion is?
Yeah, passion.
Yeah.
What are you interested in?
Yes. Actually, diagnosing the venous disease patient is very important because in Korea, some bad doctors make the ultrasound image artificially, so for their economical benefit. So actually, I heard that also in the United States, it was a great problem. So they made some very strict protocols for their own. That is, IH guideline is very important right now. So we always depend on our doctors' conscience, but some doctors are not. So for the benefit of a patient's health, we have to make this kind of protocols. Yes, and we also will develop in the future more. Yeah.
Thank you.
Are there any questions? And the one small, a short question from me.
Yeah.
And that you also are thinking about that kind of the accreditation of that duplex cross sound for the venous disease.
Yeah.
So what I'm little wondering that how do you think about that kind of motivation for the doctor to have the accreditation or that your protocol, like, because that there is no reimbursement system for that accreditation, or in Japan, also in Korea, and that, but we also facilitate them to have the kind of take the protocol. So how do you think?
Yes, especially in venous shield or radiofrequency ablation, EVLT is covered by private insurance company. So, and also another stripping and ligation is covered by government reimbursement. So there some indication is different. So we try to make them together. Actually, surgery indication that audit is very severe in our government. By government, we try to very strictly make the purpose of that kind of ultrasound images. So we try to make them together.
Okay. Thank you very much.
Thank you so much. Thank you.
Last speaker is Michihisa Umetsu Sensei, and from the Tohoku University. The title is that adverse event with a China create closure varicose vein, a large-scale national survey in Japan. Dr. Umetsu Sensei, please.
Okay.
Dr. Umetsu Sensei. Yes.
Can you hear me? Okay. Okay.
Little bit at the voice is weak.
Okay. Slides. Okay. Hi everyone, and thank you, Chairman, for this great opportunity to speak at the Worldwide Vein Week.
Okay.
Okay. I'm Michihisa Umetsu from Tohoku University Hospital. I'm very sorry I couldn't visit beautiful spring Nara. It's an honor to be here today, especially with colleagues from Korea. My talk is about a national survey on adverse events with cyanide closure of varicose vein in Japan. Here's my disclosure. Let me start by looking at the history of endovenous procedures for varicose vein in Japan. In 2011, Elvis laser 980 was approved, and in 2014, Elvis laser 1470 and radial to link fiber, and also RFA closure fast was approved in the same year. And the latest procedure, Vinacil cyanide closure, was approved in December 2019. In Japan, a certification by Japanese Regulatory Committee is required to perform CAC treatment. Prior to the widespread use of CAC in Japan, a Japanese CAC guideline was published to provide knowledge of complications and share indications. The guideline highlighted the risk of infection and immune reactions as injected cyanacrylate remains in the body. It also clearly stated that CAC treatment should not be performed on patients with infected venous leg ulcers. After an analysis of the FDA's complication database, which reported a possibility of high incidence of serious adverse events in CAC treatment, Japanese physicians sought for guidance regarding the safety. So this prompted an urgent national survey to determine the incidence and outcomes of CAC adverse events in Japan. To address these concerns, urgent surveys were conducted. The first survey, conducted over 1 week, focused only on serious adverse events. And the second survey, conducted over 2 months, especially targeted major adverse events. And the upcoming third survey will delve into more detailed adverse events. In this presentation, we'll report on the second survey. The second survey was conducted from November to December 2023. And this survey focused on major adverse events such as VTE, hypersensitivity, allergy, and foreign body granuloma, infection, major bleeding, and vein resection, and mortality, and collected details of VTE and hypersensitivity. We would like to thank all the physicians who took time out of their daily practice to join this survey. And here is institutional characteristics. A total of 24,209 CAC cases from 338 institutions were collected. 52% of institutions performed outpatient CAC treatments, and anesthesia was predominantly local, and concomitant procedures such as varicotomy were performed in 31 of cases. And this is a major adverse events from the second survey. This included 292 cases of VTE, with 150 cases requiring anticoagulation. There were no cases of stroke or anaphylaxis. Localized hypersensitivity requiring additional treatment was observed in 1,656 cases. And around 65 cases of systemic hypersensitivity DVT requiring steroids and 9 cases of glue resection. There was one death after CSC treatment who underwent bilateral small saphenous vein closure and developed severe PE and bilateral DVT, which was diagnosed 2 weeks after procedure and died with pneumonia and sepsis 42 days after procedure. Among the BT complications, there were 3 cases of PE and 9 cases of proximal DVT and 95 cases of EHIT class 3, totaling 107 clinically important BT cases. And among the hypersensitivity complications, 419 had foreign body reactions requiring oral NSAIDs, and 960 had mild reactions requiring oral antihistamines, and 268 had moderate to severe reactions requiring systemic steroids. To further understand the mechanism and risk factors for AEs in CSC treatment, an upcoming survey will focus on CSC-specific AEs to understand the role of immune reactions, especially to assess the severity of the immune reactions. And patient-based peri-procedural details will be collected. And in conclusion, most of the cases were treated successfully and safely with CSC treatment, but a certain number of hypersensitivity cases required steroids and systemic allergic reactions were observed. And the further investigation of these complications specific to CSC treatment is warranted for our upcoming survey. Thank you very much.
Thank you very much, Dr. Umetsu. And Dr. Woon-Soo Kim, could you have a comment or the question to this the presentation?
Thank you very much for your great presentation. It is very difficult to construct this kind of national data in Korea. So is there any special method to organize this kind of study?
We don't have any special methods, but we had with a web based with using a Google form to for the physicians to mailing physicians to answer this questionnaire.
Thank you. And another question is, you said there were localized hypersensitivity reaction in 6.8%. And how do you treat them? And also, do you have any screening method to them?
Okay. We have for the hypersensitivity. If there is a redness or swelling and pain, with no fever, we diagnosed for the hypersensitivity. And if there were no itching, just redness or swelling, considered a foreign body reaction and treated with NSAIDs. And localized itching is present, consider hypersensitivity and treated with antihistamines. And if the systemic urticaria is present and the systemic hypersensitivity is considered and treated with steroids as well as antihistamines. The definition is very confused, but we are doing for the treatment like this.
Thank you very much.
Are there any questions from the floor? No. Dr. Umetsu, thank you. Yes. Dr. May, thank you very much for that. Your very excellent presentation, and I also hope that you find further making a paper. Thank you very much, Dr. Umetsu.
Thank you very much.
Also, thank you for that, all of that Flora doctor and that colleague and that cooperation with this session. And we close that, currently we close that this session. Thank you very much.
座長の門先生、小川先生、演者の先生方、ありがとうございました。この後はランチョンセミナーになります。お弁当を会場の後ろに用意しておりますので、お手数ではございますが、参加者の皆様は順次お取りいただき、お席にお戻りください。合わせて10分ほど休憩を挟みます。次のランチョンセミナーは12時5分より開始します。
はい。はい。はい。はい。はい。写真撮ります。いやいやいや、これスライド確認。あ、いいですよ、OK です。はい。